dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of synchronous endometrial and ovarian endometrioid carcinoma. So this is a case of a 48-year-old female patient who presented initially with abnormal vaginal bleeding, for which she underwent DNC and was diagnosed with endometrioid carcinoma. So she underwent hysterectomy and bilateral salpingo-oophorectomy. And in the endometrium, this is the scanning power magnification. And what I wanted you really to see is that the tumor was confined only to the endometrium and barely invading into the myometrium. Most of the myometrium was free of a tumor, and there was no evidence of lymphovascular invasion. Now, on high power magnification, as you can see, this is the tumor, this is the surface, and this is the area of the maximum invasion, really barely invading beyond the endometrium into the superficial part of the myometrium. And as you can see, even from this power magnification, the tumor is formed mostly of glands with some tendency at cribriform formation and squamoid differentiation. Higher power magnification, again, there is the cribriform arrangement of the tumor with the nuclei that are more or less monomorphous with minimal mitotic figures. So this would be consistent with low grade, probably grade 1 endometrioid carcinoma. Now, in some areas, squamous differentiation or squamoid differentiation was also seen. Now, what was really present at the time of the hysterectomy and oophorectomy and was not detected beforehand is that the ovary, one of the ovaries, it's mostly the right side, this was the right side ovary, was involved by tumor here. And why I wanted really to show you the scanning power magnification is to emphasize that there was no evidence of rupture of the ovary nor surface involvement by the tumor, and this is extremely important. Now, on higher power magnification, there is the surface of the ovary with no evidence of rupture, and there is no evidence also of lymphovascular invasion. Importantly, the tumor, which is endometrioid carcinoma, has the same morphology and grade, importantly, of the endometrial carcinoma. So this is mostly composed of a cribriform arrangement of the tumor with the rounded nuclei, some tendency at squamoid formation. So again, low grade endometrioid carcinoma arising or present in the ovary, involving the ovary, in the absence of evidence of rupture of the ovary or the capsule, no surface involvement, and no lymphovascular invasion. What was really important in this case as well is that both the endometrial tumor as well as the ovary were deficient with MLH1, the loss of the nuclear stain, as well as with PMS2, both in the endometrium and the ovary, consistent with mismatch repair deficient a tumor in both locations, while MSH6 was retained in both sides. So the final diagnosis in this case is synchronous endometrial and ovarian endometrioid carcinoma. Importantly, low-grade tumor, MMRD deficient, and according to the 2023 FIGO staging system, this would be considered FIGO 1A3. Remember, in order to diagnose synchronous endometrial and ovarian endometrioid tumor, number one, both the tumors should be of similar morphology and of low grade. Number two, the ovarian, the endometrial tumor should be involving less than 50% of the myometrium, so there should be only superficial invasion to the myometrium at the maximum. The tumor can be confined to the endometrium or involving less than 50% of the myometrium. There should be absence of substantial lymphovascular invasion in the myometrium, so the presence of focal lymphovascular invasion is accepted, but not substantial lymphovascular invasion. There should be no involvement of the cervix. It's important the tumor should be confined to the endometrium and the superficial myometrium. Now, the ovarian tumor, on the other hand, should be also of low-grade endometrioid carcinoma and should not show evidence of rupture or surface involvement of the a tumor on the surface of the ovary, and there should be no evidence of lymphovascular invasion. And what is really is also a very important, that there should be no evidence of distant metastasis or involvement of other organs outside the ovary and the endometrium / superficial myometrium. These are the requirements as per the WHO in order to diagnose synchronous endometrial and ovarian endometrioid carcinoma. Remember that the all-FIGO staging system used to assign a low stage 1A for the endometrial tumor and 1A for the ovarian tumor. Now, the more recent 2023 FIGO staging system, we have this category of 1A3 stage for the synchronous tumors. Now, why is it important to diagnose synchronous endometrial and ovarian endometrioid carcinoma? Because if we follow these strict criteria, patient will have only conservative management, no further treatment is required. But remember that the most recent literature supports that both the tumors are clonally related. It's extremely important. So as in this case, both the tumors showed the mismatch repair deficiency, which would support that they have common origin, but yet despite of the probable theory that the ovarian tumor is metastatic from the endometrial tumor, yet if we follow the strict criteria as described, then there is no need for further treatment or management. I hope you find this tip useful in your daily practice. Thank you.